Hello, everyone, and welcome to Prevention of Frailty and Aging. Thank you for joining us today. I would now like to introduce your speaker, Dr. Vincenzo Malafarina. Welcome, Doctor. You now have the floor.
Thank you very much, Sarah. I would like to share with you my webcam to have the sensation that we don't talk with a machine, but with a people. Before starting, I would like to invite all of you for the next EMES Congress in Berlin in 2019. EMES is very interesting in aging aspect and as demonstrated about the Maturitas, that is the journal of the society, and it is the 13th journal of geriatrics and gerontology. So I would like to thank the European Menopause and Endocrine Society to invite me to participate in this very interesting webinar, and of course I would like to thank all of you that came to this webinar. So the topic of the day is prevention of frailty in aging people. And before starting, I would like to pay your attention that when we talk about elderly people, sometimes we think about we have the image about very sedentary elderly people, but I think that it's not the true, because older adults can loud like older people, and I would like to have this type of elderly patient in these slides. From 215, Dustin Hoffman is 75, and he received a prize in San Sebastian, is near Pamplona. Okay, the background of my presentation: why is important frailty? Because frailty places older people at risk for adverse outcomes, and disability in activity of daily living is an adverse effect of frailty. And it's very important so to knowing which physical frailty indicators can help us to predict activity of daily living disability. So sometimes the most important difficult when we look the paper published is that the study utilized very different frailty indicators, but I think that we can try to understand something more about frailty. It is the summary that I utilize in my presentation, and you can see I utilize a very not normal sequence, because I would like to start with what's happened in frailty subjects, which is the prevalence of frailty, which is the most important complication and adverse effect of frailty, and the mortality if frailty is associated with increase of mortality. So we talk about how can we diagnose frailty, how we can prevent, and if we can treat frailty. As you can see in these slides, frailty is very prevalent in the population, and its prevalence increase with age. So frailty and age is very closely associated, but I would like to say that not all of the elderly or older adults are frail. So the prevalence increase because frailty is a geriatric syndrome, but it's not the age the problem, but the other aspect that we can see later. And if we do not nothing, the prevalence of frailty, as you can see in these slides, increase with years, and this increase is statistically significant. there is a lot of study that try to study. There is a lot of paper that try to study frailty and difference in prevalence of frailty, and you can see that in this paper published in JACS in 2014, the prevalence is so similar. Also for frailty index is a lot of higher prevalence, but the most important things of this paper is that frailty is associated very well with disability and with a new activity of daily living difficulty at 3 and 9 years. So another time, I think that it's very important, and it is the end of the presentation. It is very important to do some things, and not only to diagnose frailty. Because how I say before, frailty is very associated with aging, but it's not the age the problem. The problem is other aspect. And to make the frailty diagnosis is very important, because frailty is associated with functional decline. In different type of pathology, there is evidence that frailty is associated with functional decline, like in breast cancer patient, in which we can observe that short physical performance battery present a very important odds ratio of functional decline, or other very important aspect of frailty like gait speed or grip strength are very important association, have a very important association with functional decline. And you can see here that frailty is associated with age, as we know, but the most important aspect, I think, that is the frailty is associated with improve or of instrumental support and loneliness of our older people, more important than the age association with age. So I think that I would like to say that the most important things that we need to see when we talk about older people is that if we can prevent and if we can treat frailty, perhaps we can improve quality of life and the onset of disability in this type of patient. And in another very important pathology that is very prevalent in elderly or in older adults, it's heart failure. And we can see in this very interesting paper published last year in European Journal of Heart Failure, we can see that in the same type of pathology like heart failure, patient with frailty present a very important increase of mortality respect patient with heart failure but without frailty. And another important aspect that we can't forget is that frailty is associated with adverse outcomes, but also frailty is an adverse effect of pathology like myo-osteoporotic fracture. We can see that after myo-osteoporotic fracture, the prevalence of frailty increase so much. And in this other paper, the author tried to say the same things, which is the most important predictive power of frailty index, and they observed that all of frailty indicators are associated with activity of daily living and instrumental daily living disability, but after the adjusted analysis, we can see that gait speed is the most important indicator of disability. And there is a very interesting cohort study in Spain, in Albacete, from Dr. Avisanda, that published the most results, and I think that is an interesting paper published in Maturitas a few years ago, in which they observe and try to observe the importance of frailty in onset of disability, and they distinguish disability in activity of daily living as basic activity, daily living, or mobility like transfer or walk or use stairs. And they have a follow-up of near 2 years, and they observe that frailty people have a very high prevalence of physical disability, more than non-frail subjects. And this is true in a lot of healthy problem in our older adults, like patients that need cardiac surgical procedures, or in patients with anemia and are hospitalized, or in patients with inflammation state. To understand the diagnostic tool of frailty, we need to understand the phenotype of frailty. In 2001, Linda Fried present this image in which we can see that is very important. There are a very important aspect that are associated with frailty, and this aspect is the loss of muscle mass that now we know as sarcopenia, the important aspect like chronic undernutrition or desnutrition in our older adults, and so a loss of total energy expenditure, and these important aspects are all associated with frailty, and are associated with cascade on frailty, in which concur a lot of physiological, psychological, and biological aspect. But I think that is important that we distinguish frailty from functional deficit, from disability, and so from death, because frailty is associated with sarcopenia. Perhaps sarcopenia, we can see sarcopenia like an early stage of frailty, but the most important things is that frailty is not disability, and but if we do nothing, perhaps frailty people present a very high risk to present disability, and so we can return to healthy status. But if we treat frailty, we can improve the physical status, and we can establish a normal muscle function and muscle mass. I try this. I present these slides because sarcopenia in 2016 received a code of ICD that is M62.84. Sorry. So I think that it is very important, and I hope that the same procedures are needed for to recognize frailty like a pathology, not only like a research topic, because frailty is a geriatric syndrome. And for this reason, I think that we need to update the review that we published in Maturitas in 2012, in which we talk about sarcopenia like a very important pathology, but without recognize ICD code. And you can see here that perhaps the first screening tool for frailty is the frailty phenotype presented for Linda Fried in 2001, and she talked about 5 very important aspects of frailty that are exhaustion, weight loss, low activity, slow walk or slow gait speed, and very low end grip strength or grip strength. And more than three or more of these 5 criteria are diagnostic for frailty. And I say before, frailty is very important. Frailty is associated with disability, frailty is associated with comorbidity, but these 3 entities are different. They can have a point of I will say a point of in which the 3 pathology or the 3 problem are associated with, but we talk about 3 different entity in clinical aspect of our elderly or older adults. And there are a lot of easy screening tool that can we utilize in primary care. One of these is presented from Romero Ortuno that in 2010 working in Ireland and present this very interesting screening tool that we can utilize in primary care, because it utilizes only 5 questions that we can do to our patient, and they observe that not frail are less present less ADL difficulty, and also that frail is present a very important limitation in instrumental activity or daily living. And another very easy, I think, first step to do the frailty diagnosis is the gerontopole screening tool, frailty screening tool, in which we can we can see that there are only very easy questions that we can ask to our patient to have an idea that if our patient presents frailty, and so we can do a very important and deep diagnosis and correct and more difficult diagnosis. And but we need a lot of screening tool to diagnose frailty, but sometimes we don't utilize it. So for this reason, Oliver Bruyère from SKO joined with the European Union of Geriatric Medicine Society and the Frailty group, research group, do this online survey in which they ask to clinicians which is the typical tools that they utilize in clinical practice, and they observe that the most simple aspect of frailty, like gait speed, is the most utilized tools to have an idea that our patient need a deep diagnosis. And the other very important aspect is short physical performance battery, that is very easy to do in clinical practice, and we only need to improve this in our clinical practice to have an idea of the physical functional status of our older adults. And in the same survey, they ask to the clinician which is the reason for the clinician utilize and would like to assess frailty, and the most important answer is that the clinician recognize that frailty people are at high risk of falls, hospitalization, and death. So if we recognize and if we do a correct diagnosis of frailty, perhaps we can improve the healthy status of our patients. So that is very important, and we have a lot of tools that are very simple, like in nursing homes. There is a validated screening questionnaire that can represent the first step of diagnosis of frailty. But it's very important. The question is very important to know the frailty status. I think that sometimes it's very easy to recognize frailty people, but sometimes we can have sometimes we need a most difficult tools to understand that if these older adults are frail, or this other one that need a lot of medication, but no, perhaps he is not frail, or the other one that is hospitalized. And frailty is very linked to the normal life, or I prefer to talk about real life, because one of the most important aspects of frailty is gait speed. That it's, I would say before, it's one of the most simple tools that we can utilize in everyday clinical practice, because gait velocity or gait speed is important to cross a street with red line, and so people that with normal gait speed can do a normal life. But also in 2011, Stephanie Studesky published in JAMA this very interesting paper in which we can observe that only for a very low difference in gait speed from 0.6 or 1.1, we can observe a very important difference in survival year of our patient. And we talk about for an 80 years old patient, a difference about 7 years old in women or in men. So I think that another important aspect related to this aspect is that not only people with a better gait speed live more, but also they present a better quality of life, because they are more autonomous, and they present a normal state of necessity. They don't need help to do the normal life at their home. And also gait speed is very important, associated with falls that is a very important geriatric syndrome, because falls is associated with fracture. It's very difficult to obtain a fracture if our patient don't present a falls. And the gait speed another time is associated with recovery. We published this paper 2 years ago in JAMA, and we observed in hip fracture patients admitted to a rehabilitation unit that patients with better functional ambulation category previous to the hip fracture present a better recovery of activity of daily living, or better recovery of walking ability, and aspects that sometimes are more important, like cognitive impairment. Yes, it is important, but less important than walking capacity. So, can we do something to improve our the frailty status of our patient? I think that yes, I think that is not an impossible mission. We published with my research group a systematic review about nutritional intervention in sarcopenia, and we included 17 papers, and we observed that oral nutritional supplementation in sarcopenia are associated with improve of muscle health, and this improve is better if oral nutritional supplementation in desnutrition patient is associated with exercise, because exercise improve the muscle metabolism. And another time, we need to forget that age is the problem, because there are a lot of older adults that have not problem with muscle, with sarcopenia, and with frailty. So we need to talk about sarcopenia and brow frailty like geriatric syndromes, and we need to do something to improve this aspect. And we need to beginning with the most simple aspect of treatment, like oral health, because it's very the 2 years ago an interesting Chinese study demonstrated that occlusal force is the point that can help us to understand the association with about protein intake and walking speed, because a patient with reduced occlusal force eat less meat and so eat less protein. And another time this year in Oral Disease Journal, another very interesting paper demonstrate that elderly with remaining teeth report less frailty and better quality of life than edentulous. So I think that the first step to understand the treatment of frailty and sarcopenia is to understand the real problem of our patient, of our older adults. So patient with without teeth perhaps don't need a very strange intervention. Perhaps they need a better quality or better health, oral health, and because it is very, there is a lot of evidence that dietary protein intake is associated with loss of grip strength. So I think that is very important that we talk about the improve of protein intake in our older adults, healthy older adults, but more in ill older adults. And sometimes the physician, like I am a geriatrician, so sometimes the physician are utilize restriction to the patient, but sometimes we need to improve the quality of diet. And last year we published another systematic review about nutritional aspect of frailty, and we published the paper in Maturitas. We included 32 papers, and we observe a lot of results, but I would like to explain you only one today, and that is that if we increase the dietary the protein intake in the morning, in the breakfast, people with more protein intake in breakfast present loss of frailty versus patient of older adults that have a low protein intake in breakfast. It is very simple to understand, and I wait for 2 slides. And in these slides, the results are the same, and we can see that patients with frailty have a very high prevalence of malnutrition, but not frail are not associated with malnutrition. The prevalence of malnutrition in frail is 8.3, and the prevalence of malnutrition in not frail is 0.3. So it's very important difference in malnutrition aspect in frail and not frail subjects. And how I say before, I would like to go to the finish of my presentation, to the end of my presentation. We can see that nutritional support plus exercise play a very important role in improving muscle function, and so in muscle health, as presented in this review published from the group of Luc van Loon, that is a very important group that study the muscle metabolism. And muscle metabolism is very important in frailty and in sarcopenia, because in feed status the gastrointestinal system is the origin of nutrient for all of the other organ and systems. But in malnutrition state, I would like to talk about that the muscle is our supermarket. So the muscle is the origin of the nutrition to the other organ and system. So if we lost muscle mass, if we lost muscle function, we lost quality of life and functional in the ability in activity of daily living, instrumental activity of daily living. Can we do some things? We publish the protocol of my PhD project some years ago in Maturitas, and this year we published the first results in which we can observe that we supplemented patients with hip fracture with nutritional supplementation during admission in a rehabilitation unit versus patients that receive only the normal hospital diet. We included 49 patients in the is a randomized control trial, and we included 49 patients in the intervention group and 43 in the control group. And we can observe that there are no difference in the basic baseline aspect of our patient, but we can see that oral nutritional supplementation is one of the most important factor that permit that our patient don't lose appendicular lean mass. And how we can see in these slides, we can see that in blue intervention patient and in red control patient, and control patient present a loss of weight, but this loss of weight is associated with loss of muscle mass, and this difference is improved significantly, and loss of appendicular lean mass, and in the intervention group improve their appendicular lean mass, and the fat mass is not modified. So it is very important that during hospitalization, during metabolic stress, we can improve our patient to improve the muscle health. And I was saying during the entire presentation, because frailty is one of the most important predictor of future falls. So we need to treat frailty to treat its complication and the complication of other like majority osteoporotic fracture. And to the future, because in this moment there is a lot of paper that study the impact of frailty on disability, but there is a very few study that try to improve frailty status with an intervention. And I think that is the future. The SPRINT project from is an multi-country study that is in this moment is in recruiting, and the objective of this study is to try to reduce and to treat frailty and sarcopenia with nutritional and exercise intervention in elderly community dwelling people. To conclude, I think that it's the importance to make the diagnosis of sarcopenia and frailty and malnutrition to treat them properly. I think that the properly select of patient to be treated and to establish a concrete goal, we need to know what we what we want for every patient, treat nutritional deficiency with caloric and protein supplementation. We can do a very well diagnosis, but now we need an evidence for treatment, and stimulate physical activity is important, and prescribe post-acute rehabilitation. So, which is the take-home message that I would like to pass you? That frailty is distinguishably from comorbidity and disability, but all three concepts are closely related. A proper gain speed, allow cross the street with green line, and the main drivers of quality of life in older adults are energy, freedom from pain, ability to do activity of daily living, and to move around. So to conclude, I think that we need to we try to see the beautiful aspect of age, and not only age like an ill and a problem. Thank you very much. And so we need to we can do the if I open we present you the questions. What is the rule of, no, it is not my, it's not the question of this of this webinar. Just just a minute, please. Okay, this is the first question. What is the frailty? Please select one of the follow option. Frailty is disability state. Frailty is a state with high comorbidity. Frailty is a reversible predisability state. Okay, I don't know if we have the question of the whole of assistance. The the right question is C. Frailty is a reversible predisability state. Perhaps I'm not very clear, because frailty is a state. Perhaps is a very frailty is a state with high comorbidity. Yes, they can coincide in the same patient, but how I say, it's not the same. It's not the same. So frailty can be associated with comorbidity, but frailty is not comorbidity. We can find a patient with frailty status and low comorbidity. So the second question is, which is the relationship between frailty and nutrition? A, malnutrition is more prevalent in frailty people. There are no relationship. Or C, frailty is more prevalent in malnutrition people. Few seconds to this very important aspect of frailty. And it's very important because it's one of the most, I think that one of the most important aspects of treatment of frailty. I hope that we can see the answer of assistance. Yeah. It's the problem. Malnutrition is more prevalent in frailty people, but it's not true that frailty is more prevalent in malnutrition people. The correct answer is A. And it is the problem. Sometimes we observe malnutrition frailty people, but we can have in our ambulatory, in our hospital, frailty people with a good nutritional status. And the third question and the last question is what are the criteria of fragility phenotype? I hope that it is very easy. It from Linda Fried criteria. So the A is low grip strength, exhaustion, and low walking speed. B is low activeness and weight loss. And C is the A plus B are correct. Fragility phenotype are, I think, that are the gold standard. Sometimes it's difficult from some aspect of the criteria, but I think that is the gold standard. We need to start with a more simple screening tool, but if we would like to have a very good frailty diagnosis, we need to utilize frailty phenotype. And I don't know who is the 7% that would like to do diagnosis only with low grip strength and exhaustion and low walking speed, but the correct answer is C, because low activities and weight loss are the other 2 of 5 criteria of fragility phenotype presented by Linda Fried in 2001. So I think that we have some minutes if you would like to do some question, if you would like to ask some question. I insist on the importance of do a diagnosis and utilize a simple tools to do a first step diagnosis of frailty. Okay, there are 2 questions from Rebecca Glasser. What is the rule of, no, yes, this one, of testosterone? Yes, okay, sorry. What is the role of testosterone in the prevention and therapy of frailty in men and women? Increased muscle mass, strength, bone density, appetite, mood, energy, neuroprotection. Thank you for your question. I think that there are a lot of papers that try to utilize testosterone in treat muscle loss and muscle function in older adults, but the results are that testosterone improve muscle mass, but the testosterone don't improve muscle function, and also testosterone in non hormone deficiency is not indicated because present a lot of adverse side effects. Okay, another question from Joseph Iskaros. Patients are told to lose weight to remain healthy. It is more difficult to regain weight for the patient with low BMI. Yes, I am very interested in nutritional aspect. It is the topic of my PhD, and I think that good nutrition, good nutritional state and good nutritional intake is very important to obtain muscle health. We published with an international panel in clinical nutrition. It is on in print, and consensus about nutritional aspect of sarcopenia and frailty, and it is very important and more difficult if patient lost weight. Is more difficult that they regain the weight loss. The third question is in your randomized clinical trial, how did you deal with confounders? If the patient were given supplementation, it might be that the better results could be because of exercise, for example. What ways can one follow to ensure that only supplementation by itself works alone? No, okay. In my randomized control trial, the patient received the intervention group and control group receive rehabilitation during the admission in the rehabilitation unit. So the only one difference is the nutritional supplementation. And at the end of the study, and you can find the results in the paper published this year in Maturitas, we do an multivariable analysis. So we try to correct the results for other possible confounding factors. And we observe that oral nutritional supplementation in multivariable analysis, oral nutritional supplementation, Bartle index, and how you can see in these slides, oral nutritional supplementation, Bartle index, and the previous ability to walk are the most important factors that are associated with the loss of appendicular lean mass. Thank you for your questions. There are some more questions. We have a few minutes if you want, or if
No more questions at the moment. If anyone still has a question, please type it into the questions section of your GoToWebinar control panel. And we have just a few more moments here, so go ahead and get those questions in. But I do not see any more at the moment. Do you have anything else to share with us today?
Oh, I think that I would like to thank all of the participants for the question. I think that I am a geriatrician, I am a clinician, and so I think that now we change the point of view, and now we focalize our attention in what can we do to improve our patient physical status and health status. And it is very important to do a good diagnosis, but after a good diagnosis is very, very, very important to do some things. And all of the paper are agree that if we improve physical function, health status, and reduce the prevalence of frailty, we can improve quality of life, and we can improve the survival and the survival of our patient. So we need to talk about prevention, because it's very important to prevent frailty. It's more easy to prevent than to treat, and I think that it is the take-home message.
All right. Well, thank you, Dr. Malafarina. I still don't see any other questions, so I think it's safe to go ahead and call this webcast a wrap. So thank you so much, everyone, for joining us today. Enjoy the rest of your day, and this now concludes today's broadcast. Thanks so much.
See you in Berlin.
All right. Thanks.
Bye-bye.
Bye-bye.